Head of Neurological, and we have Dr. Srikant Venkatakrishnan with us for the faculty.
You're not audible.
So, can you hear me?
Yeah.
So, sorry for the inconvenience. And once again, good evening to one and all, and welcome to our 8th session, neurological assessment for the patients. And today we have Dr. Srikant Venkatakrishnan with us as a rehab physician, and he had completed his MD in PMR from St. John's Medical College, Bangalore, and he have completed a fellowship program in NIMHANS, an established PMR department at Narayana Health Hospital, and he is working as a HOD at Narayana Center, and he is specialized in the treatment of people with complex impairment causing disability, and he manages patients with neurological, cardiopulmonary, musculoskeletal, and rheumatological diseases. He is working as a rehab team head at Narayana Health. Many physiotherapists, occupational therapists, speech therapists are working under him, and he aims to build to be a bridge between the medical professionals, engineers, and stakeholders to make rehab innovation cost-effective and inclusive. We are happy to be. We are very privileged to have you here, sir, and I welcome you to for the session. And over to you, sir.
Thank you for that very kind introduction. Thanks to Tips and Echo for organizing this. Sorry for the mild delay. I had to attend to a certain patient emergency. So I cannot share the screen. Is the presentation, can it be put up, or how is it going to be?
Yeah, sure.
Or should I, if you enable screen sharing, I will put it up from my end.
Enabled only, sir. It's enabled only.
Enabled, huh?
Yeah.
Oh.
Yeah.
Right. Is it visible?
Yes, sir.
All right. So I won't delay further. This is a very large topic. Some of the areas I was asked to cover include the assessment of neuropathies and their management, assessment of stroke and addressing activities of daily living, and a few scales to assess ADLs, and the management of stroke impairments. It's a very sort of, you can err on the side of giving too much information, or you can give nothing at all. So I've tried to strike a balance between the two. Without further delay, I'll proceed. Now, when you come to talk about neuropathies, irrespective of the cause, what we would want to do to help patients is to look at the impairments and then treat based on what we see, irrespective of the diagnosis. The diagnosis and the other medical aspects will give us a clue on how the disease will progress and will alter our plans. But mostly we are looking at the impairments which are in front of us, and then how we can ameliorate the symptoms based on what the patient and the family wants and based on the settings. So when you talk about the assessment of neuropathies, we need to look at the history and exam. We will talk about what investigations will already have been done and what we will encounter in such a situation. What are the functional implications due to these impairments? What problems they face and how we plan to manage the patient effectively. So when it comes to history taking neuropathies, we need to look at the temporal characteristics or how the illness presented, because that will have a bearing on what the progression or the prognosis will be. So we need to have an idea of what was the onset, how long it has carried on for, and has it plateaued? Is the condition still deteriorating, or is there improvement? Many a times with conditions like GBS, you will see that there is nadir up to even 28 days of the onset of the disease. So at that time, we cannot give measures to strengthen and cause fatigue. We need to be watchful and then give subthreshold activities. So the progression of the illness has a bearing on how we manage the case from a rehabilitation perspective. What are the symptoms that we will encounter with neuropathies? Most commonly, you will see weakness, pain, imbalance, or when it involves a hand clumsiness or reduced grip, numbness of the hand, or a sensation of walking on cotton when it comes to the leg. You will have falls. And in terms of the distribution of symptoms motor wise, they help to correlate which structure has been involved, whether it is a peripheral nerve, the plexus, root, or any other structure. There is a certain pattern of involvement when it comes to each of these conditions. And also you need to pay attention to what reflexes that we will come in the examination section. And when it comes to the motor symptoms, you have to see what bearing it has on their ability to feed, dress themselves, how they are able to comb and take bath and do the day-to-day tasks. One important thing in neuropathies when it involves the lower limbs is that when they walk, the sound of slippers becomes more exaggerated when they're using Hawaii slippers. So we ask them, after, do you feel that the slippers are more noisy? Do you feel difficulty in gripping the slippers? Do you feel that the slippers have slipped away and you have walked ahead? So these are some of the motor and sensory symptoms. And also there is the wash basin phenomenon, where in the evening the patient goes to the wash basin to wash their face. There is imbalance. Now what happens when they wash their face, put the water, they close their eyes. So the sensory feedback from the lower limbs is absent. At that time they feel the sense of imbalance. And you should also ask for any skin changes, increased sweating, drying of skin, trophic changes which point to an autonomic involvement. So we need to localize with our history whether there is sensory, motor, or autonomic predominant. And based on the geographical distribution of symptoms, whether it is focal, multifocal, or only peripheral versus proximal, or symmetric and asymmetric, which will help us with the planning for the management. And importantly, we have to come to the soft aspects of our history, not only the routine medical aspects, but also how it affects the activity of the patient and their functional ability. What are the psychosocial issues involved, which are going to either hinder or facilitate our rehabilitation? Because a lot of these patients will have chronic diseases, will be worn out because of the disease, and the family will be burdened by all the issues that are happening, the expenses, the lack of earning member. They also have to double up as a caregiver. Their earning time is lost. So what is the level, the socioeconomic status? What is the support system? Whether they have a disability certificate or not? These are important issues to see in your history. And where are you assessing the patient? How is their home environment? At what level do they stay? What kind of flooring do they have? Are the toilets Indian or Western? Do they have a toilet? Is there plumbing within the house? Is there a threshold at the toilet level? Do they have stairs? How many stairs to their home? Are there railings? What is the access to public transportation? These are very important questions to ask in your socioeconomic and home environment history. And importantly, many of them will already be referred to you after going through a lot of treatments. So they may or may not have assistive devices already with them. So it's important to know whether what they already have is appropriate, and whether you need to prescribe and get them new appropriate assistive devices. So that should also be a part of your history. And in your exam, you need to look for general information in the general examination that will aspects which might interfere with your rehabilitation, such as the nutritional status, their habitus in terms of body weight, whether they're leanly built, whether they're obese, how are their skin and nails, which will indirectly give a marker of the nutrition, whether they have pallor or not, and which would point to anemia and thereby a poor endurance for physical activity. And this will help you to plan your sessions accordingly. And even though we are talking about neuropathies over here, in the central nervous system, you also need to look at their mental function and also their orientation, because many a time these will be patients with complex multi-system issues. They might be delirious. They might also have additional issues like a concomitant stroke. So you need to know whether they will be able to follow what you are planning. So in terms of their memory, their orientation to time, space, and person, level of alertness, the ability to follow multiple step commands, these are all important in your plan. And then go on to the musculoskeletal aspects of your examination, where you look at the bulk and the pattern of wasting, the tone will give you information on whether it is a lower motor or upper motor neuron lesion. And an important aspect, the most important aspect, is the power charting through the manual muscle charting. And you need to have accurate charting of all the groups in whatever range of motion that is available, and whatever powers you say are based on the range of motion of each joints that are available. So you need to have a thorough understanding of what is the full range of each joint. And that will be a huge strength which you will have as physical therapists, because most of our training is based on these aspects. Just a quick question. Can somebody tell me how you will differentiate LMN versus UMN lesions? Anybody? You can put it in the chat box as well. Any comments? All right.
So we have some answers in our chat box, like down, deep tendon reflex, mass, flaccid or spastic.
Yes, so tone will be reduced in LMN lesions. The DTRs will be sluggish or absent in LMN lesions. And MAS, so MAS is the modified Ashworth scale, which will be, so spasticity is relevant, hypertonia is relevant in UMN lesions. Also, sometimes they may have fasciculations in LMN lesions. And grossly, you're looking at areflexia, weakness, and hypotonia in LMN, which is probably the opposite. You may not have wasting in UMN lesions, and your spasticity will be there. You might have clonus, and there might be an upgoing plantar response. That is one of the easiest first things that I go and do for a patient is the Babinski sign. And if that is upgoing, then I know, okay, there is something that is UMN happening. Right. Thank you for your responses. And on the same note, we look at the reflexes. What is the pattern of sensory distribution? That is very important, because you will also prescribe protection techniques, how to prevent against burns. A lot of these patients, they will say, let me just see how I feel when I pour hot water on my feet. Oh, it will be good to pour hot water. And then, if I get sensation with that, they will use that as a sensory integration technique. I have seen 2 patients of mine the last 6 years who have done that and burnt themselves. So you need to have a good examination of the sensory system, so that you can educate them that what are the things that you should not do, how you should take care of your feet, how you should take care of your hands, how in the kitchen, whether you can use gloves, use protection when you're handling utensils, better to use wooden utensils. These are all the activity modifications you will suggest based on the sensory findings. And then when it comes to conditions like diabetic neuropathy or Hansen's, whether there is a loss of protective sensation in the feet, which can interfere with their foot care, cause recurrent ulcerations, and that can predispose to adverse events such as amputation, sepsis, and even mortality. So it's very simple measures, such as asking them to inspect their feet daily, moisturize appropriately, clean, and then not keep it wet. These aspects will go a long way in making sure that you prevent ulcerations. And then part of your exam will also be that functional ability, where you look at the ability to transition from bed to sitting, sitting to the chair, sit to stand, transfers to the toilet, their stability during taking baths, whether they're able to take bath on their own, how they're able to ambulate on even, uneven surfaces and on stairs. And when you come to other CNS conditions, communication and language will be dealt with separately. So when it comes to a motor impairment, you will generally look at these domains. Then it comes to the gait of the patient. 1 second. So always your examination will always be incomplete if you don't comment on how they ambulate, whether they can ambulate or not. Do they need wheelchairs? Do they walk with person support? What kind of gait is it? When you have steppage gait, as you can see over here, they will have increased exaggerated hip flexion to compensate for the loss of ankle dorsiflexion. And when you have a white-based gait. They usually have a white-based gait in sensory ataxia, any kinds of ataxia, but mostly in sensory ataxia. You will have foot drop and foot slap. In foot slap is very interesting because sometimes when there is a loss of ankle dorsiflexion power, there's not a complete loss, but suppose when the powers are 2 and the ankle plantar flexion is 5, you'll have a situation where the foot drop will not be obvious, but when they walk, they will be sort of like a slap, and then the sound will be increased. So that is termed as foot slap when the ankle dorsiflexor is not completely gone, but probably around 2 or 3. So these are some aspects of gait in neuropathies. And what are the investigations that might have been done? So usually people might have done a CT or MRI to rule out more central proximal lesions. An ultrasound might have been done in cases of compression neuropathies, such as in median nerve or peroneal nerve injuries, where they will be either thinning out or enlargement of the nerve compared to the other side. But usually, unless there is a new progression of symptoms and somebody has already been diagnosed, it is best not to over investigate and ask for new investigations. But electrophysiology, when it has been done, is important to review because it will give you some information on the prognosis. Now, when you have axonal neuropathies, you will generally find in the CMAP, compound motor action potential, there will be a reduction of the amplitude or a loss of amplitude. Whenever there's a loss of amplitude, the prognosis because there is a complete severing of all the axons. So there will be no CMAP. So in that case, you can always plan for somebody who's unlikely to recover that function and needs compensatory maneuvers. So the impairment targeted approaches will be reduced over favoring compensatory approaches. And then when you have demyelinating conditions, usually they will have more favorable prognosis, where there will be reduced velocity on the nerve conduction velocity parameters, such as the sensory as well as the motor conduction velocities, and generally will have more favorable prognosis. And lab factors you need to review the most recent findings that will interfere or help with rehab, mostly interfere, where you have in the CBC, you need to look for anemia, which can cause reduced endurance. In the renal function, high creatinine value again will interfere with tolerance for physical activity. And you need to look at the total protein, albumin, and other factors that can complicate your rehabilitation. Now, what are the aspects that you need to see? Most of them, some of them I've already covered, but you also need to look at it in a stepwise approach where you handle bed mobility, transfers from one surface to the other, hand function, and in hand function, you need to assess their grasps and grips, the grip strength, writing speed, and tests for dexterity. You need to identify what kind of prehensile function that they have. How is their pincer grasp, the tip to tip, the lateral grasp, the mass grasp, and mostly all these patients will compensate with lateral and mass grasps. And you might have patients with ulnar neuropathy where there will be clawing and weakness of intrinsics, which will help you to identify the correct activities you need to give for their strengthening program and also to plan for splinting. And then you go on to dressing, whether they can, based on the impairments, whether they need to do single limb dressing or they need assistance for overhead activities. How are they able to groom themselves? Do they need assistive devices such as long handled combs or long handled brushes? Are they able to feed themselves? Sometimes in patients with neuropathy will have reduced hand grip, so the rice will slip off. They may not be able to tear chapatis. So please elicit that history. Are they able to bathe themselves? You know, when they have sensory attack, they will not be able to stand stably. So they might slip in the toilet. They might need a commode chair, or they might need a stone to sit on. You may need one person's help to do it. And in terms of toileting and transfers, how is their mobility for that? And how do they ambulate on even, uneven surfaces and over stairs? So what are the diagnoses you can encounter? They can either be mononeuropathies, named neuropathies, a small spelling mistake there, it should be only a single N. So peroneal neuropathies, ulnar, sciatic, radial, these are the common neuropathies that are seen of different etiologies. They can be traumatic, toxic, infective, or drug-induced. And also they could be commonly, you see, polyneuropathies, those who are completely disabled and bed-bound. Initially when they're discharged from a hospital, they are more likely to have something like GBS, which has acute motor axonal, motor sensory axonal neuropathy, and acute inflammatory demyelinating polyneuropathy, which are parts of GBS. And then you have CIDP, when the duration of the progression is more than a month to 2 months, then it goes more into CIDP. When the nadir is, or when the trough of the illness is within 1 month or 28 days, goes more in favor of GBS. And the treatments will vary based on that. These patients, some of them in CIDP may have also received steroids, so that will complicate matters in terms of adding on to proximal myopathy, and their bone strength, calcium metabolism will be affected by this. So you need to look at early weight bearing whenever feasible, and also be careful that when you're weight bearing, what is the duration to which they have been bed bound. So based on the diagnosis, the treatment, your plan will vary. Now, how do your plan will be based on when they present. Sometimes when you lose a lot of time, your goals can be limited, going to take more time for rehabilitation. How severe the illness is, and what is the nature of the illness? Is it due to an oncological related process? Is it because of is it because of a drug-induced neuropathy? Or is it something that's traumatic and the insult has happened in the past, unlikely to progress? Many times with oncological illness, you will see that there is a downward progression of graph in terms of their function. But when you have traumatic and one-time events, sentinel events, at that time it becomes much easier to plan, because the prognosis, whatever has happened, may not change that much. All you need to do is to prevent complications, prevent contractures, prevent wound formation, manage the pain, improve the strength. So it becomes easier to plan once you know what is the nature of the illness. And importantly, consider the patient and family. How burnt out are they? How much they will accept what we are saying and planning for them? Is it going to be feasible? Get to know them better, because only when you know, when they empathize with you, will you be able to do something meaningful for them. And then what are the resources and settings that are available? Many a time we will not have in-house orthotics. Many a time they will not be able to afford because they already spent a lot. So how you can liaise with different organizations and NGOs to identify particular needs that are going to help them plan, so that you can make a difference in the quality of life, and then liaise accordingly, set them up with people who can then get those resources for them, or how you can identify resources nearby that are cheap and cost effective to help them either with assistive devices, or also whether they have access to government disability services, whether they have a disability certificate, how you can set them up with a social worker or a government institute. So for that, you need to know what is around them and how they can access those facilities. And this is probably the most important thing, that even if your theory is shaky, this is something that is going to help everybody. The communication, it is important to give them time, not to interrupt, listen to what they are saying, and have that concern, because people are not fools where they will just accept whatever we are doing. We are all struggling in our lives to do our best. But suppose we have the frustration of the previous patient or our day, or the lack of patience to understand what is happening in our eyes, and they will know that. So it's important to put all that aside, connect with them and empathize with what they're going through, saying things like, I understand what is happening, I know it's difficult, but we can plan. We can think of micro gains. We can work on this. Once that happens, once there is a connection, then they will follow what you say. It becomes much easier for you to say, okay, this 1, 2, 3, 4, 5, this is the prescription for you. This is what you need to do. Once you have done this hard work, they are going to follow what you say. And it's important to share what you know. There is at the right stage. Rehabilitation is a graded process. It is not going to happen overnight. We all know that, but it's important that they know it, and they know it in a graded fashion. Sometimes you can overload them with information. Sometimes you cannot tell anything. We have to have a balance, what we tell, when we tell, and it's important to share honestly what the prognosis is going to be based on the illness. Now, we cannot have unrealistic goals as well. And we also need to focus on specific goals to be set at particular times so that they are achieved. And it's important to involve all the stakeholders, the primary physician, the referring physician, the surgeon who's involved as much as possible. Because if there is a complication, you need to refer them back, because then mostly what somebody will say is you just go to physiotherapy, you'll be fine. But sometimes, you need you need them to revert to the primary physician. And at that point, if you have a conversation with the whole team, it makes things easier. The other people also get involved in the care. They get involved in the rehabilitation plan, so that it's not something that is just, oh, my job is done, you take care of it after that. Then after that, if something happens, no, I've done my job. No, it's not going to be like that. You need to interact and get everybody involved in the process of rehabilitation. And after having done all this, make a concrete plan and strategize for the patient. Now, this is a real ocean, the techniques, how to manage impairments. But we'll just cover a few things. And I can learn a lot from this group, because there's a very huge group over here, and hopefully I will learn some new things. So for hand function, somebody has difficulty in writing. Can somebody give an advice to me how that can be managed? Either you can talk or in the chat box. So for if somebody has difficulty in writing, grip strengthening exercises, all right. Using non-verbal. What do you mean by using non-verbal? Precision handling techniques, yes. Also grip modification. Sometimes strengthening, it's a long-term thing. So you can ask them to have devices with built-up handles. You can increase what I do sometimes is I take a tissue paper. Can you see me? I take a tissue paper and I fold it, and I just roll it over the pen so that the grip is thickened. And when the grip is thickened, their intrinsics don't have to act tightly, and that eases their burden. It works for some, doesn't work for others, but no harm in trying. Yes, so yes, assistive devices in terms of a C-bar or a pen holder, all these things will work. And also you need to give them specific instructions how to simple exercises to help with strength, such as using the clips of the cloth and attaching them to the sides of a book, grain sorting for precision, folding a paper into 4 and then tearing it into small strips, picking coins and putting it into a slot. These are some techniques that are useful in an ambulatory setting. And in terms of activities of daily living, ask them to break down their tasks. Suppose they're not able to dress in, they don't have dynamic balance, then break down in position of as much stability as possible. Get them to lie down and don clothes, donning and doffing to be practiced with reaching tasks in the lying down position. Ask them to sit and wear clothes. And because mostly we are focusing only on the physical impairments, but focusing on their day-to-day tasks and ADLs is going to go, even if you address it a little bit, it will go a long way in improving the quality of life. And it's important to have a graded program that focuses on pain management with techniques such as breathing, mindfulness, modalities. And it's important to translate what you want for the patient in terms of how to maintain the range of motion. It's not just that passive range of motion is going to help. You also need to help them by telling them to use sustained stretch for at least 8 to 10 seconds, repeated 10 to 15 times, at least twice to thrice a day. That is going to help with their range of motion, and activities to improve their motor control, balance and coordination in terms of graded reaching exercises, stepping exercises. It's not that balance only includes tandem walking, but even variations of it, stepping on squares, creating squares for them using pens, sketch pens and tapes, and also endurance training with simple tasks. You don't need a cycle. You can just ask them to step on the spot, note the time they take, gradually increase the endurance for that, and have a structured program that is function based. Because when we focus too much only on the impairments and developing precision, the idea of improving the independence gets lost. To some extent, we must also focus on their function, so that apart from improving the shoulder range, maybe we should also look at their better trunk control and ability to reach. And each program has to be customized. Better to avoid customized handouts for each patient, even though it saves time. But when we create a written program, maybe we can also draw and give them that. When we invest that time in patients, it's going to be more better appealing, and they will accept it a bit more. They're more likely to follow it. And as much as possible, try to avoid jargon, simplify the language so that they can understand. So this was a little bit about neuropathies. And assistive devices, when you look at orthotics, you need to know what to give when. And most commonly in foot drop, you will have a patient with weak dorsiflexor. It's important not to give AFOs straight away. You need to know what the dorsiflexor power is. If it's the dorsiflexors are 0, and then you have some plantar flexion action, you can give a posterior leaf spring orthosis, or the AFO with trim lines behind the malleolus. And then when the powers are completely 0, even plantar flexors are 0, that is when the AFO will be useful, both as a resting splint and also for ambulation, if and when it is feasible. Otherwise, you have to manage with ankle stabilization techniques. To some extent, crep bandaging helps, but doesn't serve the purpose. High arch shoes. Basically, the aim is to stabilize the ankle with an external support when they ambulate. And it's important to liaise with anybody. It can be anybody, the shopkeepers nearby, stationary sort of clinical surgical stores near the hospital, near their houses, social workers. And if you have a tight program, if you have a good program, you can always promote yourself for the benefit of patients, so that more resources are poured into what you do. And you need to educate them on how to use the assistive device correctly. What is the height of the walker? What is the height of the crutch that is ideal? You have to have the gripping near the level of the trochanter. The tip of the cane should be 6 centimeters out and lateral to the lateral toe. And the elbow should be flexed at 20 degrees. You have to be specific on these instructions so that the patient is not spooked. They don't use it in the wrong way, and how to care for the device appropriately without damaging their skin. So these aspects, so you need to talk about intermittent splint wear, and it takes time. I think when broken down into several sessions and when explained clearly, it helps the patient with safety. So what are the red flags? I mean, when to ask for help from other specialists? When there is worsening of pain, for which medications and certain interventions might be considered. When there's worsening of the symptoms of weakness, when contractures have happened, when the knee FFD goes beyond 30 degrees, and there is good power proximally, there's only knee flexion contracture, that is when probably they need a surgical consult. When they can walk, a release of the hamstrings can be helpful. And when there are wounds that are not healing, the wound nature changes, when there's exudate, when there's pus, there's inflammation around. Look out for all these signs in anybody with neuropathy. And that is when you need to ask for help, either from a surgeon or a physiatrist, or when there are psychological issues, a psychiatrist, palliative medicine specialist, when there is severe pain. So these are some aspects to consider. Next, we move on to stroke, very divergent from moving on from LMN to UMN. And there is only so much we can cover in our lives and in this session. So I'll try to be as brief and succinct as possible here. So what is a stroke? It is a focal neurological deficit from a vascular cause. And most strokes are ischemic. About 85 to 87% of strokes are ischemic because of occlusion of the cranial blood vessels. And mostly you have anterior circulation strokes, followed by the other kinds of strokes. Then you will have bleeds within the brain due to uncontrolled hypertension or aneurysms, aneurysms. And these are called ICH or subarachnoid hemorrhage, bleeding into the subarachnoid spaces. And then you will have CVT or cortical venous thrombosis, seen commonly in females using contraceptives. So there will be backflow due to the CVT, and that will cause infarction and loss of blood supply because of the venous blockage. And generally you find that the prognosis of stroke varies based on where the stroke is. So where the stroke is and also the size of the stroke. Larger strokes, recovery happens less, and the site of the stroke. If you have the tracts, the motor tracts, when they are affected, such as if you have a bleed in the capsule, internal capsule, then the recovery will be less. But in a bleed in the brain parenchyma, recovery might be more. So where it affects the size of the stroke, and even CVTs have a generally good prognosis for recovery. You have a young adult female with the craniectomy done post CVT, you might find that she has 0 powers today, 2 weeks after stroke. But if it is a CVT, then very likely that they will have a good recovery from the stroke. So these are the prognostication factors. Whenever you have the FAST is an acronym given for public knowledge, so that people reach tertiary care centers fast, so that effective interventions such as thrombolysis and thrombectomy can be done. So you're talking about face, arm, speech, and the time. So the spatial deviation, arm weakness, the speech slurring, and the time. So if the time, there's a golden period, you have to present within 3.5 hours for stroke, so thrombolysis can be done. Between that time, 3.5, 4.5 hours to 6 hours, still you can extend the thrombolysis window. If on the MRI, there is some region in the brain which is in the ischemic penumbra, that time you can do a thrombolysis and still save more neurons. Then 6 hours, sometimes now they have extended, they're trying to extend the thrombectomy. Thrombectomy, you do a mechanical thrombectomy when you can't do a thrombolysis, they're beyond the window for thrombolysis, but still you can extract the clot. And there are very few centers that do that, but when available, it saves a lot of neurons. In fact, we've seen a lot of patients for whom mechanical thrombectomy was done, and they had almost full recovery. But again, that depends on the age and other factors such as comorbidities. What are the territories that are involved in stroke? You have anterior territory, where there are the classical MCA territory or ACA territory infarcts, and you have the posterior territory, where you have the vertebral artery, basilar artery occlusions, cerebellar syndromes, and all these syndromes such as Wallenberg syndrome. So more in the anterior territory stroke, there will be gross weakness and sensory loss. If it's the left-sided stroke, you'll have aphasia. If you have right-sided stroke, you'll have visuospatial impairment. There are posterior circulation strokes, you'll have more of dysphagia, sensory symptoms, ataxia, and autonomic symptoms, bulbar dysfunction, emotional dysregulation, and the like. So the prognosis of stroke depends on when you start your intervention. The earlier you start anything, whether it is the surgical thrombolysis, medical interventions, or the therapy, the prognosis, the likelihood that you will help the patient is more. Generally, they say within 6 months is the golden period where your rehab interventions will bear more fruit. However, that is changing with time. We found that even patients with chronic impairments can have sustained improvements. But generally, the earlier you act, the better. And as I mentioned, the site of stroke has a bearing on how the recovery will be. When you have the tracts involved versus the cortical strokes, these will have more severe impairments, and also the size of stroke. So what will you assess? What is the duration of symptoms they have presented? What is the time for which they have had this spectrum of symptoms? And what are these symptoms? You will have weakness, numbness, tightness, spasticity. They will not say spasticity, they ask for tightness, pain, which can be both nociceptive as well as neuropathic, So CRPS is very common. So just check for the arm pain when patient with stroke come to you. Arm pain on passive C as well as volar as well as extension of the fingers, swelling of the extremities, facial weakness, dysphagia, communication and mood issues. They will have cognitive issues and inability to follow commands. Mobility will be impaired, and they will be functionally dependent. And stroke, being a very disabling condition, places even more significant caregiver burden. And there will be psychosocial issues because even the personality of the patient will change. When you have neuropathies, okay, you can deal with it to some extent. When you have stroke and then you have other inflictions such as cognitive impairment, becomes much more difficult. And then the loss of an earning member, the caregiver has to double up as they have to leave their job, they have to take care of the patient at home, income is lost. So these issues you need to address. And similarly, the accessibility of the home environment, what is the social support, and importantly, how the diabetes, how these comorbidities are controlled. When you have poor control of these comorbidities, such as a higher HbA1c in stroke patients associated with poorer functional outcome. So you need to see whether they are adherent to the medical treatments, how is the diabetes controlled. That will have an impact on the functional performance as well. So in patients with stroke in the acute period, you need to be careful about their vitals as well, in terms of, because they will also have other comorbidities. The blood pressure might not be controlled. You may have somebody with aspiration, so you'll have high respiratory rate, saturation may drop. So in the acute period, you need to look at these aspects. When you're auscultating, always look for conducted sounds or reduced sounds, which might point towards atelectasis, because somebody is always being lying down, is likely to aspirate, the lower lobes might collapse, and need to work on the bronchial hygiene as well. The cardiovascular system, look for the regularity of the beats, because sometimes when you have irregular pulse and an unaddressed arrhythmia, which has caused the stroke, that can also impact activities such as upright standing, because they might have syncope. And look for added sounds, any murmurs, which might point to either valve abnormalities or anemia, which might affect the endurance. The abdominal examination, look for a loaded colon, because bowel habits might be irregular in stroke when they've been lying down for a long time and they've not passed motion for several days. This is a commonly encountered complaint. And in the central nervous system, look for perceptual impairments and neglect. When it comes to the language, generally people with left MCA territory stroke start off with global aphasia and gradually move on to a motor aphasia, and then we'll have word finding difficulties. Just a small question. Suppose you have somebody with a left MCA infarct, upper limb powers are 1, lower limb powers are 3. You have another person and he has aphasia, global aphasia. You have another patient with a right MCA infarct, upper limb powers on the left side are 1, lower limb powers are 3. Which patient is going to walk faster? This is a question for anyone. Anyone wants to answer that? You have two patients, left MCA infarct, right MCA infarct. Both have the same powers on the affected side. Who is going to walk faster?
So the second one.
What was the second? I forgot.
Second one, the one which is not having the aphasia, the problem of aphasia.
That's an interesting response. What they found is people with aphasia can be trained better with procedural tasks. When you have visuospatial impairments, such as those with right-sided strokes, it is, whatever you do, they might sort of, aberrant postural responses will be there when you make them sit. So once you get the sitting balance, then you can progress. But for them, their orientation to the plegic side itself is severely compromised. So you will have to work doubly on, proprioceptive facilitation techniques to reorient them to the plegic side. You find that left-sided strokes tend to ambulate better. So you're right, Tarun and Murugavel. You're right in that the anybody with left-sided stroke is easier to manage mobility-wise than a right-sided stroke with perceptual impairments. But once the perceptual impairments settle, you've done enough reorientation, changing the position of the bed to face the window, talking more from the affected side, more joint compression to the affected side, more sensory integration to the affected side, getting them to reach for objects or communicate by presenting them from the affected side. You have to work harder on them. Whereas you don't have to do all that for a left-sided. Yes, we do see people with gaze preference with left-sided MCA infarcts, but generally mobility-wise they're easier to manage. So moving on with cranial nerve deficits, you need to look for facial nerve palsy, which will affect their ability to manage their oral secretions. So you have to work on that as well. Bulbar palsy, where their dysphagia will be presented because of these issues. So you look at their gag, palatal movements, asymmetry of palatal movements, tongue movements. And then coming to the motor examination, where you check for the tone. Now, early on in stroke, you will have hypotonia, which then gradually progresses into hypertonia, and then the movements come in a synergy pattern. So you have the Brunstrom stages, which are useful to guide your recovery pattern. And also you need to be mindful of what synergy pattern it is going into so that you can break that pattern. Importantly, you need to know the range of motion at the important target joints, which will be the shoulder, the elbow and wrist. Initially, you will have impaired going a few days to weeks into stroke, they might develop CRPS. So they'll have pain on wrist movements. So you need to be careful over there. So know what is the range to begin with, and know what is the range when they start having symptoms. And shoulder is always a villain in stroke. It can either drop down, it can get stuck inside, frozen shoulder, subluxation, part of CRPS, tendinitis. So many things can go wrong at the shoulder. So it's important to know what is the baseline assessment, what is happening at the shoulder. Check for subluxation with your finger. What is that sign called? What is the sign in the shoulder that indicates subluxation? Anybody? Yes. Yes, that's right. So, so you can either have 1, 2, or 3 fingers. Needs to be managed with positioning and sling at the worst case, or a humeral cuff, and with NMES as and when available. And when you assess the powers, look at the voluntary control in the presence of the tone. Comment on the tone. How is their hand function, grasp, release, how the forearm movements, how they manipulate objects, how can they reach, what is the ability to do bimanual tasks. You have the Brunstrom stage of recovery, where initially there will be flaccidity, and then there is an onset of spasticity and some voluntary movements. In stage 3, there is increased spasticity. Voluntary movements improve slightly, but spasticity predominates. Movements are in synergy pattern. Then there is decreased spasticity. Voluntary movements slightly improve, but synergy pattern predominates. Then you'll have stage 5, where the spasticity further reduces, and you will have movements that start coming out of the synergy pattern. In stage 6, the spasticity goes and movements are mostly voluntary. In stage 7, you'll have normal movements. And then you have these different synergy patterns in stroke. It's important to know how they are developing so that you can plan your facilitation techniques and your as well as inhibition whenever you have to have a mix of Brunstrom as well as Bobath approaches. And also look at their functional mobility in stroke. How are they able to sit? First thing when we see a stroke patient, we make them sit and see how they're doing. Of course, if they're collapsing, then they need support. Please make sure they don't hurt themselves. But see what is the sitting balance like. Early predictors of stroke recovery or ambulation function are a good sitting balance and also finger extension movement. If you can have good finger extensor and good sitting balance, more likely that at 6 months they'll be independent ambulators. And also, what is the chronicity of recovery? Do periodic assessments so that once they develop proximal traction response, develop and facilitate the next group so that by 2 weeks you have responses at the elbow. Because poor prognosis is when once a movement comes proximally, if it is not followed by recovery distally more than 2 weeks later, then the natural recovery will be slower. So we have to work more on compensatory techniques. And also look at the trunk balance, pelvic control in terms of ability to bridging, rollovers from side to side, coming to sit, static and dynamic sitting balance, transitions from sit to stand if possible, and transfers to same level or multiple level as it might be appropriate. And when it comes to gait, there are so many things that can go wrong in gait in stroke. You cannot always achieve perfection. If the goal is to get a patient to walk from A to B, at some extent, we must allow for compensatory, but maximum we must try to manage to get the correct pattern back. We need to balance both approaches. So in gait, you have to look at the symmetry of stance, the ankle and knee kinetics in the stance and swing phase. Commonly, you see recurvatum in stance because of ankle plantar flexion spasticity, where in mid stance, because of a plantar flex foot, the weight line passes in front of the knee and causes an extension moment of the knee joint. You might have restricted flexion in swing, which can be addressed with TheraBand assisted gait training. Or even if you don't have a TheraBand, use cycle tube, cut the cycle tube and use that in place of it. Yes, may not be ideal, but in resource limited settings, these are some things that work really well. And then focus on weight bearing, equality of weight bearing, rhythmic auditory cueing to help with progression of gait, the stability, and also whether the need for assistive devices and the speed. So our aim is to reduce the cadence, try to increase the stride length as much as possible. And the speed is critical because whatever we work on function, doesn't matter if somebody needs to walk with 2% support. We need to get balance, stability, and speed. So there has to be a natural progression into these domains. Somebody will be community ambulant only if they can walk at a speed of 0.8 meters per second. If you get lower speeds, they are likely to be indoor ambulant. So it makes a huge difference how they walk. So all our stepwise graded intervention should be at improving these parameters. Then we look at activities of daily living and instrumental ADLs. As I had covered in the previous section, this is mostly the same. But when it comes to stroke, we also look at the communication function, whether they can communicate with language or with gestures or with assistive technology. Assistive technology can be low tech as well, whether they are just pointing out, whether they have a card with objects placed there, whether they use a stick to point out what they want. Even that is functional communication. And also social cognition in terms of interaction with people, how is their emotional continence, whether they have maladaptive responses such as emotional incontinence and crying. So in stroke, these are other aspects to look at their ADLs. And in terms of their instrumental ADLs, we look at the ability to cook, take care of their home, leisure, can they get back to work? Are they involved in laundry and shopping? These are things that need to be addressed as well. And scales are very important in any neurological conditions. And in stroke, we look at modified ranking scale, Barthel index, the Scandinavian stroke scale, motor assessment scale, and FIM. These are commonly used. And esoteric scales for hand function are the Fugel-Meyer assessment, the Wolf motor test, Action research arm test, and Jepsen-Taylor hand function test, which require a few devices or which are commonly available, but not very feasible in a routine practice. But the above scales which are mentioned there, they are more easily done. We come to the modified Rankin scale. You have stage 0, they have no symptoms, so it is inversely related to the function. Stage 1 is they're able to ambulate independently and able to carry out all their usual ADLs. In stage 2, they have slight disability. They're able to look after their own affairs, but they are not able to carry out their previous activities. In stage 3 is somebody who is able to walk without assistance and requires some help. And mostly the ambulant stroke patients we see will be either in 2 or 3. In stage 4, they are unable to walk without assistance. So in the initial phase of stroke, they will be MRS 4. They have moderately severe disability. and they need assistance to attend to their bodily needs. Stage 5 is when they are bedridden, they have severe disability, they are incontinent and require constant nursing support. That is in the acute phases. Stage 6 is death. The Barthel index is very easily done even without this piece of paper. You look at feeding, bathing, grooming, dressing, bladder bowel function, toilet use, transfers, mobility on even surfaces, and stairs. So in these, only feeding, bathing, and grooming have 5 points. You have 15 points for transfers and mobility on even surfaces. So total points are 100. Coming to FIM, so the functional independence measure is very useful for stroke because it addresses aspects of communication and social cognition as well. If you see the Barthel index, it does not have these aspects, whereas the FIM has a motor subscore and a cognitive subtotal score. And in this, there is a lesser ceiling effect, meaning that you can elicit functionality in a more specific way. Smaller changes in function can be picked up better with the FIM score. So here you have a total score of 126 with a minimum score of 18, addressing these aspects. The problem with FIM is that if you want to project that you're using FIM, that it is a paid scale. So sometimes you'll have to approach the university and say that you're doing this, and they might sell it to you for whatever they see is fit, but usually it's between 25 to 30,000. And as an organization, you can always plan for it and approach. You can go online, look for FIM, and then what they do is they ask for requirements, and then they will get back to you. They will give you training and a test, and then they will give you the certification to use the FIM. When I was in my PG, we used it very commonly, but when it comes to publications, using the FIM is a bit tricky because sometimes somebody who knows about rehab research might ask, have you paid for it? And then you might end up with problems. Or the university, usually they don't probe people too much, but it's better to, if you're doing things properly, it's better to purchase it. So that's why we use the Barthel index, MRS, Scandinavian stroke scale more on the discharge summaries to be more, to be safe. But FIM is a better scale because it addresses aspects of communication and social cognition as well. So the advantage of scales is that they quantify the current functional status. You can also use them to quantify the progress and identify priority areas where you can build on their function, so that you ensure an all-round approach and not only focus only on the mobility. The problem with it is that there are ceiling effects, and not all scales can pick up subtle defects or subtle impairments with the precision of other scales. So how do you manage stroke? Again, it's an ocean here, but some few pointers. Initially, you look at the bronchial hygiene, the ability to sit, the ability to cough, so that improves and prevents complications of atelectasis. We start off with tone normalization. We initially work off when there is flaccidity, look to develop tone with facilitatory techniques, and then inhibit tone with methods such as sustained stretch and the Bobath principles, where you normalize, try to normalize movement control, and also techniques such as upper limb weight bearing, early standing. Sometimes here we use the standing wheelchair as well in our stroke patients to help with tone normalization. And that has actually been a very useful addition. Sometimes a tilt table can cost anywhere between 12 to 30,000. A standing wheelchair is more portable, has a disadvantages of not being able to use it in patients who have orthostatic hypertension because it suddenly comes up to stand. But it is more portable and can be widely used in stable patients, so that early weight bearing and tone normalization can happen. And then you work on development of voluntary motor control through functional tasks, appropriate positioning, especially of the shoulder and the other joints, positioning of the ankles, using resting splints wherever indicated, work on the functional trunk mobility, develop hand function through facilitatory techniques, but also useful judicious use of mirror box therapy and constraint-induced movement therapy. I find that constraint is very useful, and with the prerequisite that somebody have at least 15-30 degrees of elbow extension and a power of 3. Not all patients come to that extent. So generally I start off when the power is around 2, and then I ask them to tie a sock to the affected side, get a new sock, and then tie either a crepe bandage or the sock for about 2 to 3 hours. This is a modified CIMT, so that the exact prescription for CIMT includes tying for around 5 to 6 hours for 6 weeks, which sometimes is not feasible, because if you had patients who the caregivers have tied them with a crepe bandage and then they've developed ischemia of the hand. So it's best to sort of give this technique only when you can supervise adequately. And then you also focus on bimanual tasks and reaching activities. Then ADL skills, importantly, if you can teach the patient how to dress themselves with single limb, do single limb ADLs, simulate activities such as grooming, dressing, and also instrumental ADLs such as helping out in the kitchen, sorting clothes. These go a long way in improving the quality of life. Can somebody tell me how to wear a shirt with one hand in stroke? All right. Am I?
So we can modify the buttons with the Velcro or something like that.
Okay, but we don't have tailor. The beauty of working in the modern world is that there is YouTube. And even though I didn't know all these techniques a while back, sitting with an OT and even YouTube helped me. And there are different, the internet is full of nonsense as well, but there are good videos once you search through. A useful way to dress with one impaired hand is that ask the patient to take the sleeve of one shirt, put that sleeve on this hand, pull it right. Can you see me?
So your hand is not visible, sir.
Hand is not visible. Okay. Is there a shirt here? Perfect. Can you see me?
No, sir. Actually, so your face we can see, sir.
Only face. Oh. One second. Can you just hold it back? Visible?
Yeah, now it's better, sir.
I am a stroke patient and I have this classic synergy pattern. Sometimes stroke patients have difficulty in identifying left or right, dressing apraxia. So you need to work on that as well with cueing. And for a moment, even I had a difficulty right now. So maybe I should get a MRI. So now I take this shirt, put the sleeve inside, pull it all the way up, then like this. So if you can tell this for patients, I hope I'm not wrong. Yeah, shirt has really bad stitching. Yeah, so this is the way to help stroke patients do single limb dressing. All right, moving forward. And then working on the gait, we look at equalizing the stepping, graded weight bearing. Sometimes you can use a gaiter to start off with early on, the powers are 0. As the quadricep starts developing, the knee starts locking. Then you stop the use of gaiter. So use facilitated techniques, use NMES to the quadriceps to maintain the muscle bulk. Build on the knee strength, and then you can wean off the gaiter. Then equalization of stance phase with weight shifts, and then you use techniques to improve the kinetics of gait, such as with a TheraBand tied to. If you go online and search for TheraBand assisted gait training in stroke, there'll be a lot of videos that are very informative, techniques that help to facilitate dorsiflexion as well as hip flexion. Usually in stroke, there is a synergy pattern where the lower limb are in extensor synergy. So there'll be restricted knee flexion and restricted ankle dorsiflexion and restricted hip flexion. So automating the process with a TheraBand goes a long way in making sure that you are not, you don't need two people to stabilize and move the knee and ankle as you want it to. And then train the caregiver. It's not enough that we are doing all the hard work. Sometimes we can get distracted and forget to say anything to the person sitting nearby. And when they see our dedication and see that effectively we communicate, they will do what is required and we can double the time, which, we give a home program for the patient. If it is adhered properly, our outcomes will also improve. And the same advice for assistive device and orthotics. Generally in stroke, we use an AFO and resting hand splints. If you don't have one, I have had one patient use a ruler and a mat in lieu of a gaiter. They didn't get gaiter, so they used a long cane, bamboo stick, and a mat, and that worked well. But just supervise what they're doing. We can a lot of the time the patients also innovate, and we need to not be complete Hitlers or Putins. Maybe I should not make political comments here, but yes, we should allow them to do what they can, but still ensure safety and educate on how to use the proper height of canes and proper device care. When they develop pain, CRPS, severe spasticity contractures, ulcers, infections and UTIs, that is when you need to ask for help. Thank you.
Thank you, sir. Thank you very much for that wonderful session and updating the stroke and its management and also its rehab reception. Thank you very much, sir. And we can keep 1 or 2 minutes for the participants to ask any doubts or something like that. And after that, we have to move on for the case presentation. If not, I think we can move on to the case presentation. Today, a case is presented by Ms. Shobana Subraj, and I request Shobana ma'am to start for the presentation. Over to you, ma'am.
Good evening, everybody. I'm Shobana Subraj, working as a block physiotherapist in Perepalem GPH, Yelabaram block, Thiruvallur district, Tamil Nadu. I have been working here for 2 years, and previously I worked in a rehab center for physically and mentally challenged children for about 13 years. At present, working under state government's MTM program, Makkali Thedi Maruthuvam, for the benefit of the palliative care patients, even in remote areas. Before going into the case presentation, I would like to thank ECO and Trivandrum Institute of Palliative Science for providing such a beautiful opportunity for us to refresh our mind, and also for Dr. Srikant, who has presented an excellent assessment on neurological assessment presentation. It is very beneficial, sir. Thank you very much, sir.
Thank you.
Going into the case presentation. Today we are going to discuss about a case of a 6-year-old girl who had been admitted in hospital on 2/1/2021 and was discharged on 16/1/2021, diagnosed as subacute sclerosing panencephalitis. It is a condition of a slow virus disease caused by persistent mutant measles virus infection. A defective expression of either matrix fusion or hemoglobin protein of measles virus is responsible for the persistence of the virus in the brain cells, and it escapes by immunosurveillance mechanism. Next slide. Presenting complaints: she has an absence of speech, involuntary bowel bladder movement, swallowing difficulty. She was initially able to swallow only liquid diet, and now she's able to swallow semi-solid diet. She's unable to sit without support. She has a limited upper and lower limb movements. Next slide. History of illness. At the time of admission, she has difficulty in walking for around 2 months, difficulty in speaking for 2 months, difficulty in swallowing around a week, loss of memory and recognition, loss of bowel and bladder movement, though she have no history of fever, throat pain, facial puffiness, or a joint pain. Next slide. On examination, the child was conscious but not oriented. She could recognize her mother. She was unable to stand without support. She had a truncal ataxia, which is characterized by uncertain starts and stops, lateral deviations, and unequal steps. She has an intentional tremor of both upper and lower limbs, generalized seizure, dysphagia, no murmurs, and no organomegaly. Moving on to the tone. Her upper limb tones was increased both right and left. Lower limb, there was a positive tone. Power, upper limb power, both right and left was around 3. Lower limb powers were around 2. Next slide. Treatment and significant investigation. Investigation, the IgG antibodies by ELISA and CSF fluid is 625. Her cardiac waves was normal, no murmur. Respiratory system, brachial artery embolism was present, no added sound, no organomegaly. EEG shows myoclonic jerks and diffuse slowing of waves. CSF was clear, colorless, no cell seen. MRI brain was normal. Treatment, anticonvulsant drugs to control seizures, antiviral agents, immunomodulators that are given now. Intraventricular route into the CSF to control measles, and physiotherapy part, prevention of bed sores. To prevent bed sores, we can use foam mattress, regular inspection of the skin, use sweat-free absorbing cotton clothes, regular turning and changing of the position. Next is proper positioning. We are able to make her sit in a proper position at the corner of her room, using pillows around her to support, and also standing using splints with support. And we can use facilitatory and inhibitory techniques to normalize the muscle tone, as sir already said, using quick stretches over the muscle belly or tendon to activate the agonist and relax the antagonist, prolonged stretching to lengthen the muscle range that activates the antagonist and inhibits the agonist, approximation compression of the joint space applied in weight bearing position. Traction can be given manually at the beginning of the movement to improve mobility and initiate movement. Inhibition pressure manually given over the muscle belly or tendon that inhibits the muscle involuntary activity. Light touch and strokes can also be given to inhibit the generalized movements. Next to the bowel and bladder movement. Bladder training can be given following a fixed wiring schedule. Bowel training requires a fixed schedule by making the child sit in a squatting position. Next slide. Psychological aspect, maintain a non-threatening positive attitude, counseling of the family members, give information as necessary only, and good support. Next, sir. Medications, isopressinosone 500 mg, half tablets thrice a day, which was given as an anticonvulsant drug. Pacitane was given as an inhibitor of parasympathetic nervous system. Isopressinosone is an immunomodulator drug, Pacitane 20 mg, half tablets twice a day was given as an inhibitor of parasympathetic nervous system to relax the muscle. Valparin 200 syrup 5 ml twice a day given as an anticonvulsant. Next slide. The main concerns are physically she was not able to sit or stand without support, slow jerky movements of upper limb and lower limb, poor bowel and bladder control. Psychologically, she was a very talented, active girl with a clear sound speech. Socioeconomically, her father's a milkman with poor economic status. Spiritual, their parents, with their poor economic status, they are struggling to bring back their child to normal. Next slide. As on whole summary, she's a girl of 6 years, has been affected by measles after immunization and has been bedridden for a year. The poor family, having an eldest son, they are struggling hard to restore her life. Discussion points. How often is the risk of SSPE after measles vaccination? What are the possible rehabilitation of SSPE? What are the risk factors of SSPE and how to prevent it? Thank you, everybody.
Thank you, Shobana Subraj, for that wonderful presentation. We have seen that discussion points that are the discussion points were like how often is the risk of SSP after measles vaccination, then what are the possible rehabilitation for this condition and the risk factors and how to prevent this condition. I request our participants to put some inputs in the beginning stage first, and after that we can get the suggestions and this one from our faculty, Srikant sir. First, I request our participants to give some inputs. You might have seen this patient. Actually, yesterday in our group, we have sent a YouTube link
Yes.
telling the story of this child. You might have seen that child. As far as I understand, they were giving a good inhibition and facilitation technique for that child. That was a good. That will give a good impact on her. Any other inputs or suggestions from our participants? If not, we can move to Srikant sir.
So I'm having a doubt.
Yes.
Wanted to know from the ma'am, what type of bladder it was? Was it a spastic bladder or a flaccid bladder?
It was a flaccid bladder, ma'am.
It was a, so ma'am, in bladder retraining, what you have done for the patient?
We have taught to the parents, but still she's not able to control, and they say they do it in she do it in her clothes itself.
Okay, so ma'am, if it is a flaccid bladder, so should we go with the Creed's maneuver in this condition or not?
No, the girl is very small and she's weak too, and she's not able to respond to that.
Okay, so will it be a good practice if we teach this Creed's maneuver to the parents if the child is small and is not able to understand or follow the command?
Yes, her mother, she's always with her, so I felt she knew better than me than at what time she wants to do her toileting activity. So she might have observed her at what time she does bowel and bladder movements and all. So it's better to teach her, and she may go along with the girl's daily routine.
Okay. Okay. Thank you so much, ma'am.
Thank you, ma'am.
Thank you, Mamta ma'am, and thank you, Shobana ma'am. And over to you, sir, Srikant sir.
I just want to make a comment on the previous question. It's difficult to, so generally in SSP, when you have these diffuse encephalitis, the bladder is usually, when there is involvement of the centers within the pons or even the cord, that is when it's generally affected. So in such cases, in patients with diffuse encephalopathy and cognitive impairment, we cannot really comment on whether it is flaccid or spastic, which are very broad definitions. I think one has to take a history of when the void is happening, how frequently the void is, what is the volume. Only based on the age, the child's bladder volume changes. I think for her age, it might possibly around 100 to 150 ml. Then see based on the volume, how frequently the void is happening. And the only way to know the status of the bladder really is through urodynamics, and also, which may not be required in this case, and also through examination of the upper tracts, whether there is sustained detrusor hypercontractility causing reflux nephropathy. That is the main risk we are looking at. So our goal will be to just manage with behavioral techniques in terms of timed voiding, fluid optimization, and also improving the transferability of the patient to get them access to appropriate resources, or even get a local carpenter to see if he can do something to help out with, with limited resources, how they can fashion a toilet chair. And these are some of my comments on this aspect. Another thing I want to ask was, what was the functional status of this patient when we go back to those slides? One more thing, Pacitane is a 2 mg. 20 is a higher dose. So this is at discharge?
Yes, sir. And now she is much more improved, and she's able to sit without the pillow support in a sofa or a chair directly.
What is her functional mobility?
She's only able to stand with the support. When her father makes her stand, she's able to stand without buckling of the knees, and she's able to walk if he makes her to walk using her feet. Her father uses his feet to move the girl's feet.
Okay. She's conscious, and at how is her cognitive status now? Is she oriented?
She's not able to speak anything, but she's recognizing her close relatives, her father, mother, brother, grandparents.
How is her vision?
Her vision is normal. She's watching TV.
Okay. So in such a case, we also look at multisensory stimulation and object identification, making picture stories, try to see if we can get her to do some sketching or play activities. For ataxia, sometimes we find that weighted cuffs help to some extent. And also Frankel's exercises might be useful. But of course, if we can have a follow-up with the patient, that would be better, because once if you just tell them, may not have much benefit initially, but if there is a follow-up, then coordination exercises in a graded fashion will help. So what is the swallowing? Does he have cough on swallowing liquids?
So initially she used to take food at bed by lying. Now she's able to eat by sitting. She's able to swallow, but her mother feeds her using spoon and the posterior half of the tongue. If her mother presses with a spoon, and she's able to swallow.
So we must ensure proper positioning during feeds, make sure that there is at least some degree of chin tuck, modified consistency, because we don't know the exact state of the swallow. So start off with semi-solids and then work on corrective positions, just chin tuck and graded increase in liquid intake. One more. So I think in the ideal situation, when we have liaison, when there is support, we can probably, for this case, look at identifying a donor for probably a wheelchair, or a chair with proper supports, and have a cardiac table, or and such that at least the child can do activities sitting if required. Neck control is good, is it?
Neck control is good, sir. Now at present it's good.
So aim must be to increase the time spent out of bed, and it's always difficult to obtain the resources for them, considering their socioeconomic status. But then once if you are involved with a large group, then you can always try to see if you can mobilize something for them, either through Lions Club. For example, it's always important to see what is around you. So we have these charitable organizations such as Mercy Trust or Lions Club. When you approach them, they give what is required. But a problem for children is always that pediatric wheelchairs are not appropriate. I mean, the wheelchairs are not appropriate. Pediatric wheelchairs are hard to come by, and you need proper follow through to help with children with disability. Adult wheelchairs can be easily got. Then again, you need wheelchairs with removable armrest so that the transfers become easy. So in this case, we should also probably look at activity modification and energy conservation measures for the parent, see how they are lifting the child to make sure that they are not getting into any repetitive stress injuries. Also counseling them to take care of themselves, their diet, their sleep, so that they're not overburdened with disability. At the same time, they can be slightly more fresh to deal with this unfortunate situation.
So her parents are looking after her very well, and each and for every functions also they are carrying her with them, so that she sees everybody around, and she really enjoys with playing with other children. But while other children are playing, by seeing them, she enjoys herself. So for that, her mother usually engages her by keeping her sitting outside to see her other children playing themselves.
I think that's good. They have good dedication, but at some point they might get burnt out. So you have to be watchful against that. But hopefully things will, they will learn to live and give the best for this. Thank you. Thank you for your nice presentation.
Yes, sir. Thank you, sir.
Excuse me, sir. I want to ask a question. Like in case of spasticity, we know that the tone is increased. So for testing the muscle power, we should go with the voluntary motor control, or we should go with the traditional Oxford scale?
The traditional scale is also good enough, but you have to mention in the presence of mass 1 or 2.
Yeah, so it is always good to go with the voluntary motor control.
Both.
Okay, both.
But when you are saying the powers, so power is 3 in the presence of mass 1 spasticity of the elbow flexor. So mention that, so that sometimes what happens with interventions, we're looking at, for example, the quadriceps patient will have mass 1 or 2 at the knee extensor. When you say the quadriceps power is 3 to 4, they're locking the knee well. Then unfortunately, if you look at, if we try to break that either through medication or giving an injection, Botox or something, then it will weaken. So it's always important to have that line in the presence of spasticity. And that qualitative comment can be made that patient is using spasticity for this. So sometimes spasticity is not always an undesirable thing. Spasticity will be useful in weight bearing. So it has to always be mentioned when you are talking about the motor power. So you can mention the spasticity separately, like in terms of the tone. But when you're commenting on the power, say the power is this much in the presence of this much spasticity, and the voluntary control is poor, fair, or good.
Thank you, sir.
There are some inputs on our chat box, and Judith Ages type like contraindicated activities for the child. Can you explain?
Does the child have seizures?
She had previously, sir, but for 6 months, she haven't got any seizures yet.
I think we'll go vestibular stimulation must be avoided. Vestibular photic stimulation, these must be avoided here. And also the focus must be more on trunk rather than looking at ambulation right now. I think if we look at too much of passive ambulation, while it is good, it must be balanced with developing the trunk control. So it's not really contraindicated, but yes, one must balance the approach. But absolute contraindication here will be a vestibular stimulation, such as rocking or using a swing to develop postural control. These must be avoided for it.
And Tarun was asking something. Would you like to go, Tarun? Tarun, please unmute yourself.
Sir, we can't hear you.
It's not audible, Tarun. We can't hear you. No, not. Actually, there is some problem with your headphone or something. Actually, what he was typed in chat
Now
box.
can you hear me?
Yeah. Now you can hear.
Can you hear me now?
Yes, yes. Can be heard.
Okay, I'm sorry.
Taran, you want to ask something? We can hear you. Not now. Before we were able to hear you. Okay, actually, Taran was typing in our chat box like, is she at stage 3?
Yes, she was in stage 3.
And here mentioned that if she's on stage 3, then take care of stage 4. That is a life threatening. And why she is having tremor? I think he was asking.
Sir, I'm not able to get you.
Ma'am, a participant Taran was asking, is she having tremors? And
Yes, she's having intentional tremor.
intentional tremor.
If she wants to hold any object in her hand is having some tremor.
Okay.
While initiating a movement, she gets tremor.
Mr. Murugavel was mentioned that I think we can use gutter frame for, or if not available, then maybe high table to support forearm and stand, since her upper limb has reasonable power. Thank you for that input, Mr. Murugavel.
That's a valid point.
Yes, sir. Is there any more comments or doubts coming from the participant side? If you have any suggestions or comments, we can discuss in our WhatsApp group also about about this case. Actually, there is a video in our a link we have shared in our WhatsApp group regarding this case. If you have not seen that, you can go through that again, and again we can discuss in our groups. And as we are running short of time, I think it's time to wind up this session. Thank you, Shobhana ma'am, for that wonderful case presentation. Thank you, Dr. Srikant Venkatakrishnan sir, for giving your inputs and suggestions on this case also. And thank you for that wonderful session. And over to you,